I'm Dr. Ross. I'm a psychiatrist. I was born in Canada, went to medical school in Canada, did my psychiatry training in Canada, and then I did academic psychiatry in Winnipeg, which is sort of dead center in Canada, for about 6 years. Then I moved down here to the Metroplex in 1991. Was at a hospital called Charter Hospital from 91 to 97, another hospital called Timberlawn from 97 to 2015, and then moved to a sister hospital called UBH in 2015. Also consult to programs in Michigan and in Los Angeles. And the foundation of the model is what I'm going to talk about today. So I'm going to give you some of the general foundational principles, and then a whole bunch of examples. I would say this, I would say that, here's what I would be thinking, this is what I would try. So tactics and strategies. And then in the afternoon, Melissa's going to go over some other elements of the model, and also a whole bunch of case examples and strategies. And then we're going to have question, discussion, potentially from 4 to 5. We'll take a break in the middle of the morning, a break in the middle of the afternoon, and we'll do an hour for lunch. So the trauma model is the title of one of my books, and it's a general scientific model of the mental health field. And the basic idea is very simple. Trauma is a big deal in the mental health field, which I was not taught, and still general psychiatry doesn't really operate that way. They pay some lip service to trauma, but it's not really trauma-informed, truly trauma-based treatment in most of the mental health field. So just in terms of the science, the model is very detailed, and I've thought quite a lot about it, and there's a lot of research predictions. So if you do this research project, the trauma model says you'll find this, whereas regular psychiatry would predict a different result. So it's not just a personal opinion, it's not just a, my intuition. It's actually designed carefully to be a scientifically testable model. So to be scientifically testable, a model or a theory doesn't have to be correct, it just has to be testable. It's set up in a specified way so you can actually do some research and actually find out, is the model or the theory correct or not? And generally in the history of science, models keep getting revised and changed and dropped, revised and changed and dropped. So no model ever captures the whole truth. An example of a different research prediction is back in 70s, early 80s, there was research done in the general population, knocking on people's doors, thousands of participants, and they would interview them and come up with standardized diagnoses. And one of their observations was, if you're out in the world, not in a treatment center, just at home, and you're female and you're clinically depressed, then your female relatives have an elevated rate of depression compared to the relatives of somebody who's not depressed. And your male relatives have an increased rate of antisocial personality and drug and alcohol problems compared to the male relatives of the woman who is not depressed. And then their conclusion was that there's some sort of genetic predisposition that's running in these families that's causing the problems, and the genes are somehow expressing themselves as depression in the women and expressing themselves as antisocial personality and alcohol problems in the males. So therefore it's genetic, and on we go with genes, brain chemicals, and so on. The trauma model has a different prediction, which it can be very depressing to be a woman in a family with a whole bunch of violent, antisocial, alcoholic men. That's totally common sense. You think it would be obvious to everybody. And you could actually test to see which of these models is correct. And we've actually already done the research, we just don't realize it. And this is all the adoptions that have taken place in the last 50 years, say. So the prediction is, if you're physically born, and you'd have to control for the mother's drug use during pregnancy and some other things, But if you're adopted at birth out of a big domestic violence, multi-general incest, depression, substance abuse, eating disorders, PTSD kind of family, into a healthy, regular family that has very low levels of mental health problems, then your risk for all those problems drops down dramatically. Whereas if you're born as a result of a teenage pregnancy in a fairly regular, halfway healthy middle-class family with low levels of trauma and violence, low levels of mental health problems, and you're adopted out at birth into the big trauma, big mental health problems family, your risk goes way, way up, which is a very different prediction from it's just your genes and it doesn't matter, you carry your genes with you. So that's just an example of there's many, 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 many specific predictions, and it's all set up to be testable. And the basic idea is that trauma's got a lot to do with it. It's not all trauma, but trauma is a big, major theme driving a lot of the problems. So another quick example would be in regular schizophrenia genetics, there's different kinds of research, and they go kind of in a series of steps. But one of the basic strategies is you want to look at identical twins and non-identical twins. And there's a concept called concordance. So concordance means if you interview some identical twins, and the first twin is female, how often is the other twin female? 100% of the time. First twin has blue eyes, always blue eyes. African American, always African American. So some traits, the concordance is 100%. Because when the first twin has the trait, the other twin always has it. So examples of diseases where the concordance is 100% would include cystic fibrosis, Huntington's chorea, there's a whole long list. So these diseases are totally genetic. And if you have the bad gene, you have the disease. If the first identical twin has the disease, the second identical twin has the disease. So when concordance is 100%, you know that it could be 100% genetic, but it doesn't have to be. Because let's take a look at Chinese twins, identical twins. Concordance for being Chinese is 100%, but so is concordance for speaking Chinese. The first twin speaks Chinese, lo and behold, the other one always speaks Chinese. So that means there's a gene for speaking Chinese? No. How do we figure out which is genetic and which is environmental? We have to look at adoption. So that's the next step in the studies. So, which is hard to do because there's not that many identical twins around who are being adopted at birth into different families. But in principle, you've got the two Chinese twins, doesn't matter if they're male or female, one stays with the family of origin, one's adopted at birth into an English-speaking family. Lo and behold, 5 years later, they're still both Chinese, but the one who's adopted into the English-speaking family speaks English. So therefore, we know that speaking Chinese or English comes totally from the environment, whereas being Chinese is totally genetic. So you can sort these things out. And the example of the different prediction is in regular schizophrenia genetics, which is kind of the brain disease genetic type model, the concordance for schizophrenia will be higher in identical twins and not lower in non-identical twins, because the non-identical twins only share half their DNA. And lo and behold, it kind of works out like that. The difference is not that huge, but nevertheless, that's the fact. And it's the same as gender. Like identical twins always have the same gender, but if it's non-identical twins, it's kind of 50-50 deal. So the trauma model has a different prediction. The trauma model prediction is, if you look at concordance in twins, the highest will be identical twins who both had lots of trauma. The next highest level of concordance will actually be non-identical twins who both have lots of trauma. Then the third highest rate will be identical twins where one has lots of trauma and one doesn't. And then the final lowest will be non-identical twins, one has lots of trauma, one doesn't. So the difference in the predictions is that, first of all, trauma has even been considered or talked about as a difference, but the specific prediction is that concordance is being driven a whole bunch by the trauma, not just by the genes. And that's why the non-identical twins have a higher concordance level if they both have tons of trauma than the identical twins where only one has the trauma. And that's going to help you to start sorting out what is the percentage contribution of trauma. So that's it for the boring science. So now we're into the trauma model book is the foundation, and that's the logic of the model. Sitting on top of that is the trauma model therapy book, which is how to do the therapy. So that's what I'm going to talk about for the rest of the morning. So the trauma model therapy has 5 core components to it. And I'm going to walk through all 5 of them, explain them, except 2 I'm only going to do real quickly because Melissa will do those in the afternoon, and then get into the examples of how it all works. So these are the 5 elements of the model. The problem of attachment of the perpetrator and the locus of control shift are the 2 core things that we work on all the time. The other principles, which I'll go through one by one, we also work on a lot all the time, but they're not quite as core, quite as fundamental. And then after I go through them all, I'll try to weave it all together and give you actual clinical examples. So the basic idea here is that our clientele is mammals. So this is a completely useless model for reptiles and amphibians. But since we don't treat very many reptiles and amphibians, it doesn't matter. If you are a mammal, one of your goals is survival. If you're a mammal and you want to survive, you can't do it by yourself at birth. You're totally dependent on adult caretakers. And so this is just a fact. There's no exceptions. It's inescapable. So therefore, you're biologically programmed to bond to, connect with, attach to, love, and need to be loved by adult caretakers. It's not an option. It's not some kids yes, some kids no. It doesn't have anything to do with your gender, your race, your culture, your IQ. It's absolutely the biology of being a mammal. And it just all kind of rolls out. So this is the basic foundation of the model. Now in a healthy family, which apparently there are some somewhere, in a healthy family, it all just kind of works out okay. So you have lots of unconditional love, you have consistent parenting, little tough love thrown in when you need it, you can take a risk and go off into the world and try something or other, you come back, you don't get yelled at, you get support for taking a risk, support whether you succeed or fail, it's all good. And so what happens is you learn that the world is a pretty safe place, people are trustworthy, you're intrinsically lovable, it's all okay. So we never see people from such families. Now I'm talking not about Healing Springs Ranch so much as the trauma model programs that I have, which is what I'm familiar with. But I think more or less the same thing applies here. The people that we see come from big trauma families, by and large. Not all the time, but by and large. And by and large means like 90% of the time or more. So big combination of physical abuse, sexual abuse, family violence, general chaos. Now I'm only talking about what's going on inside the family. I'm ignoring most of the world where the big dose of childhood trauma is really dying. Half, maybe not half, but 35, 40% of the people in your village are HIV positive, the adults. War, high death rates, high infant mortality, that's going to be where all the trauma is before we even look at the inside the family. But in North America, fortunately, we don't have all of that so much, so we're more focused on trauma inside the family. And it includes physical abuse, sexual abuse, family violence, yelling, screaming, mom getting beat up, and it also includes absent caretakers through death, divorce, their own mental health and substance abuse problems, being in jail, the first stepdad, the second stepdad, and so on. And it includes things that the parents do, which they shouldn't do, which is the active abuse. And it also includes things that they should have done that they failed to do, which is bonding, nurturing, attachment, unconditional love. So there's both active abuse and the emotional neglect, emotional abuse, not being there emotionally. It's that whole melting pot of trauma. So if you're a little person at this kind of height, you're biologically programmed to attach. You'll do it no matter what. So you love, you approach, you connect with, you need to be loved by. But the parents are very inconsistent and chaotic themselves. Sometimes they're okay, sometimes they're sort of marginally okay, sometimes they're absent, sometimes they're present and actively abusive in this chaotic, unpredictable pattern that you can't control, you can't escape, and you can't fix. So you've got automatically two reactions going on at the same time. You'll approach, connect, bond, love, attach. And then when the bad stuff is happening, it's exactly like when you touch a hot stove. So when you touch a hot stove, you don't go, I believe that we learned in biology class that excessive thermal stimulation is toxic for the integrity of the human epidermis. Therefore, I'm going to decide to withdraw my finger. It just doesn't work like that. Your thinking brain's not even involved. It's all reflex. Your spinal cord and your arm go, yow! And this is what happens with trauma as well, psychological trauma. You pull back, you retract, you flee, you avoid, you shut down. So you've got these two automatic reactions going on. Love, hate, approach, avoid. I hate you, don't leave me. This is the problem of attachment to the perpetrator. How to form a secure attachment to people who are also your perpetrators. It's overwhelmingly emotionally complicated and painful. There's no good solution to it, and you're just a little kid trying to survive in this mixed up world. Here's an example of a traumatized little kid. The reason I have this slide here is this is actually a hippo that was in the tsunami, got washed up, and lost its parents. And fortunately, there was a very touchy-feely, warm, fuzzy substitute mom available, this big sea tortoise. So this is a very touching picture of the power of mammalian attachment. You just need to snuggle in, and whether it's your biological mom or your stepmom or your adoptive mom, you need somebody. And obviously, this is not about being a human being. It's not about race, gender, culture, IQ. It's just about being a mammal. So how are you going to solve the problem of attachment of the perpetrator? You can't afford to see, know, and feel the whole picture. You've got to somehow put all that bad stuff enough out of sight, out of mind, to create an illusion for your attachment systems that mom and dad are okay, you're safe, you can bond, you connect, and you're going to live. So the only way to create that illusion is you can't see the whole picture all at once. So you got to put it a little bit, all the bad stuff, a little bit out of sight, a little bit out of mind. So in the field, there's all kinds of different vocabulary. You could call that, I call it dissociating. It's also sometimes called splitting, fracturing, fragmenting, internally disconnecting. So there's all these different terms for it, but the basic idea is you got to split it into, put some of it over there. And now you've got I'm okay, you're okay mode. And sometimes mom and dad actually are okay, and it's all fine. And then next day or next week, kaboom, they're absent, they're actively abusive, they're abusing each other, you're fearing, fleeing, avoiding, shutting down. So you go into mode B, which is I'm out of there, you're no good. But you can't stay in mode B because you're just a little kid. So the idea is there's an override of your attachment systems. No matter how much you have to shut down and be out of there, you can't afford to. You literally won't survive. So therefore, you have to activate your attachment systems, go back into I'm okay, you're okay mode, put the bad stuff out of there. And then you just get stuck in that pattern over and over and over, round and round and round and round. So I brought this MRI with me. This is actually an MRI of somebody's brain. And the white circle there is the person's skull. And it turns out the brain's got some labels in it to help you understand. So what this is showing is what's going on in the mind of somebody who comes to our trauma program who has the diagnosis of borderline personality disorder, which I'll talk about more later. But to me, borderline personality disorder is logical, understandable, unavoidable, expectable outcome of the problem of attachment to the perpetrator. But this person comes into the hospital and is very angry, and it's a woman in her 30s, say, and her presentation is, the whole intake process sucked, the food is horrible here, the nurses are so rude, I don't even know why I came here. And I go, oh, sorry about that. Tell me a little bit about, so I'm trying to distract the conversation, tell me a little bit about how things were when you're growing up. My parents. I haven't talked to them for the last 13 years. He's like a perpetrator. He's out of control. I don't need him for nothing. I'm done with them. And I think to myself, I doubt you're totally done with them. So I notice that this person is in the negative mode. She's all in. I'm out of there. I don't need him for nothing. Nobody's any good. I'm done with it. So she's angry, negative, hostile, critical. What do I think is actually bothering this woman? I think that as she's drifting off to sleep at night, a tear goes down her cheek, and she says to herself what she can't admit during the day, which is, in the day, it's, I don't need Dad for nothing. He's a perp. But as she's drifting off to sleep, if only Daddy would come back, say he's sorry, make it up to me, then I'd have the daddy that I always wanted, and everything would be okay. So she's hiding from the pain of the positive attachment, whatever little amount there actually was in real life, or if there was no positive attachment, the wish, the hope, the need for a positive attachment. She's avoiding the pain of that by staying in the negative. But actually, in fact, she bops back and forth from mode A to mode B to mode A to mode B. She has disorganized attachment, which is a term in the attachment literature. So you can have secure attachment, which is just what it says, or there's several types of anxious attachment. There's sort of anxious avoidant or anxious clingy, and then disorganized is just kind of chaotic. But I don't think it actually is chaotic. The disorganized attachment patterns that we see clinically are actually a chess game. Because this person has grown up with parents, who've been very disorganized in their attachment to her. Sometimes they're there, sometimes they're not, sometimes they're kind, sometimes they're abusive. So in that chess game, you can't possibly just have a calm, steady, consistent, secure attachment to your parents. You've got move, counter move, move, counter move. And that looks disorganized if you just glance at it, but actually I think it's a very tactical, strategic, organized attempt to survive in this crazy-making family. So that's the problem of attachment to the perpetrator. Now another person comes into the program. Her presentation is completely different. She's, in psychiatric jargon, she'd be avoidant, dependent. In the relationship literature, or the chemical dependency literature, she'd be enmeshed, codependent. She's living in a trailer park with her mom. Dad hasn't come over for the last 3 months to beat mom up, so everything's been okay. She's in her mid-30s. She's on disability. She's got no work history. She's got no primary relationships other than mom. And she's living with mom. And the reason she's living with mom is mom's a little bit older now. Mom really needs her to be there to take care of her. But actually, she's been the caretaker of her mom since she was 6 years old. But she says everything's okay. Dad hasn't come over for 3 months to beat mom up. And I'm very happy to be here, Dr. Ross. Thank you for admitting me. So there's no hint of anger. There's no borderline behavior. There's no I'm out of there, I hate you at all. So she's all enmeshed in the positive part. And she's out of touch with all the negative energy, all the I'm out of there, I hate you. But all that hatred and I'm out of there is stuffed inside somewhere. So what's my treatment goal for her? I want her to be more borderline. I want her to be more the angry, rebellious adolescent. I'd like to hear from her. Now, that guy has never been to an AA meeting. He's completely out of control perpetrator, and mom's just in her stuff, and I'm tired of being the caretaker of her. I've been doing it for 30 years. I'm going to get a life. I'm out of there. They can deal with their stuff. But as soon as she says that, or feels that, or heads off in that direction, then what happens? Uh-oh, I don't have any job. I don't have anywhere to live. I don't have much of a support system. You have to honor your parents. I guess I'm sorry, Dr. Ross, I didn't mean to say that. Everything's okay. So then she's back in codependent. So these two people have very opposite presentations. They look very different. They have different diagnoses. But underneath, it's the same problem, this unresolved, conflicted, ambivalent attachment pattern. So we're looking for that attachment pattern all the time. And the basic series of steps are, you come into the facility, so you're not out there in the world, you're not dealing with everything that's going on, you don't have access to your addictions, and so it's time to look at yourself. So you start to look at yourself, and we have trauma education group where we actually teach all this. We have handouts where it's written down, and you start to go, oh, wait a minute. Okay, so now I see the picture. So when I was a kid, I was being hurt by the people that I loved. I loved the people who were hurting me. Both things were true. I had both sets of feelings. It was overwhelmingly painful. I couldn't fit it all together. And so how did I feel? I felt small, scared, sad, lost, and lonely. So when you stop all the addictions, all the acting out, all the distractions, and you really start to look at it and actually feel it and know it, that's where you go. Small, scared, sad, lost, lonely. So underneath, there's this underground sort of cavern of unresolved grief. No matter what the on the surface diagnoses and symptoms and DSM labels and so on, underneath there's always this huge underground cavern of grief. So one of the core tasks is mourning the loss of the childhood that you never actually had, which is just a good, normal childhood. So this is the problem of attachment of the perpetrator. So who would want to go snorkeling in an underground, huge cavern of grief? Nobody. It doesn't feel very good. So in order not to do that, you stay with your addictions, your distractions, and all this other stuff. And what's the goal? The goal is balance, which is kind of a tricky balancing act. To be able to feel the love, feel the hate, feel the approach, feel the avoid, and some of the shades of different colors in between. I used to say shades of gray, but now I can't say that anymore. So it's tolerating ambiguity, more than one feeling at a time, and not just being either in this feeling or in this feeling. So that's the goal of the therapy. The second major aspect of this model is the locus of control shift. So this is like the problem of attachment of the perpetrator, in that it's not about your gender, it's not about your race, not about your culture, not about your IQ. But it's not about being a mammal, it's about thinking. It's developmental psychology. The big figure in the field is Piaget, who everybody studies in their undergraduate psychology courses. And there's a gigantic literature on how kids' minds develop, how they think, how they process things. And so we're talking about the mind of the magical child. Doesn't matter which your gender is, your race, your IQ, your culture. This is just how kids process information. So it's the mind of the magical child, little person down here. In different schools of thought. It's called the sensor motor stage, concrete operation stage, primary narcissism. There's different terms for it. I'm at the center of the world revolves around me, and I've got this magical power to make things happen. That's how all kids think, without exception. So if you're in a halfway reasonable okay family, no big trauma going on, you're a little 4-year-old girl, all of a sudden dad moves out. As far as you can tell, it's all of a sudden, but clearly, in fact, it's not all of a sudden. But for that little girl, it's just all of a sudden dad moved out. So what happened on that day? She was abandoned, she was trapped, she was powerless, she was helpless, she couldn't fix it, she couldn't escape it. So how did she feel? Powerless, helpless, trapped, overwhelmed, future just crashed. It's not a good way to be feeling. But those are the feelings that automatically, inevitably go with the reality of the situation. Except here we are in 2016 now. So this little girl's already done 4 PowerPoint presentations at her preschool class. And she's already better, handling computers and the internet than her grandparents. So it so happens that she's also working on a PhD in sociology at a remote learning institution because she saved up some money and put down her $25 online. So here we have this little 4-year-old trying to be a sociologist. She emails off to her professor and says, "Professor, I've finished gathering my field data for my thesis." Professor's a kindly guy, emails back, "Well, what are your data?" "My data are, Daddy doesn't live here anymore." Professor says, "Very nice sampling methodology. I like your literature review, but in order to get a PhD, you have to have a theory to explain your data." She goes, "Oh yeah, I forgot the theory part. Let me see here. I got it. Daddy doesn't live here anymore because I didn't keep my bedroom tidy." And that's preposterous, out of touch with reality, ridiculous, not true, no way. So now we got to decide what mental health label we're going to put on this little girl. The label I'm going to put on her is completely normal 4-year-old kid who's trying to figure out what's going on in the world. She's not using 24-year-old thinking and words and vocabulary. She's this little 4-year-old sociologist trying to create a theory to explain her field data. Daddy doesn't live here anymore because I didn't keep my bedroom tidy. So she shifted the locus of control. Locus of control just means where is the control, from inside the parents to inside herself. Not because she's bad, because she's Caucasian, because she's African American, because she's a human being, and because that's how her mind processes the information. So it's not an optional defense mechanism, it's just the way your brain does it. So why do I even bother talking about this? I bother talking about this because in the trauma programs, people come in over and 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 over, explaining out loud, as a fact, I was bad, I caused it, it was my fault, I deserved it, and that's how I deserve to be treated now by my current boyfriend, my previous boyfriend, the one before that. And so I'm listening to this over and over and over, and I'm thinking to myself, like, what's going on here? This is not possible. No kid deserves to be abused or cause their abuse. So 30 years later, why are people stating it as a fact? And this has got me puzzling and thinking, and this is where I realized, oh, this is normal way that kids think and process information. And 30 years later, the person's still in the same pattern. They haven't stepped out of that magical child mind thinking. And I also figured out that there's a payoff. So it happens automatically, but let's go back to that little girl, the 4-year-old girl. Hey, wait a minute here. I just figured it out. Daddy doesn't live here anymore because I didn't keep my bedroom tidy. I've got the problem identified, I've got it totally contained within myself, and all I have to do is tidy up my bedroom. Daddy will realize I'm a good little girl, he'll forgive me, and he'll move back in. It's completely illusory, but it works emotionally, because now you're not feeling trapped, powerless, helpless, and overwhelmed, because you know what the problem is, and you know how to fix it, which is you're going to fix yourself. And this all just rolls out automatically. And then I'm a bad little girl who's causing the abuse, or bad little boy, gets reinforced over and over and over, year after year after year, by what the parents do, don't do, don't do. And then we've got the high school coach, and we've got the abusive teacher, and then we've got the abusive boyfriend, then we've got the frat party, and then we've got the first marriage, second marriage, on and on and on it goes. People treating you that way keeps proving to you that in fact that's how you deserve to be treated. So you never get out of the pattern. But you also hold on to the pattern because there's this illusion of power and control and mastery. I'm not trapped, helpless, powerless, overwhelmed. I just have to figure out what it is I'm doing wrong. And then I'll fix it, and then life will be okay. So let's take a quick detour to a battered spouse shelter. In comes the battered spouse, which most of the time it's a woman who's being battered by a man, but we also have experience with lesbian battering relationships, and occasionally a guy is being battered by a woman, but most of the time we're talking about a female spouse, the male perpetrator. In comes the woman to the battered spouse shelter. And what does she say? We know what her behavior says. Her behavior says, I'm out of there, I'm not going to take it anymore. And usually that's what her words say as well. I'm out of there, I'm not going to take it anymore, I don't deserve it, he's a perpetrator, my kids don't deserve it, I'm done with that. And the people working there could do 2 thumbs up and give some positive feedback, provide some social resources and encouragement. Everything's good, problem solved. Until somebody looks at the intake and says, well, wait a minute, this is the 7th visit to the battered spouse shelter. What happened the last 6 times? Because each of the last 6 times she came in I'm out of there mode. I'm not going to take it anymore, he's a perpetrator. And something happened. And she went back to the guy who's hurting her. Well, what's the process there, which can take days or weeks or sometimes months? So instead of good posture, good tone, good energy, good assertiveness, good self-worth, good self-esteem, and a decision to leave the guy, we gradually start to hear, so the energy starts to drop down, the posture's not as good, the tone of voice is not so assertive, and we start to hear change in the thinking, which is, well, the economy's been kind of tough, he's been under a lot of stress, he's been working extra hours, all he wants is perfect spouse, perfect kids, perfect house, on demand, and he's been so stressed out because I haven't been a very good wife. So I'm going to go back and work on being a better wife. I'm going to do this and this and this and this and this and this. And then he won't be so stressed out, and then he won't have to hit me anymore. So it varies from person to person, but this theme happens over and over and over at battered spouse shelters, because the women do physically go back to their perpetrator, and they have to have some sort of explanation to themselves as to why that's a sensible decision. And that's all the locus of control shift. The problem's inside me. I haven't been a good enough wife. I'm going to go back, fix myself. He won't be so stressed out. Everything will be okay. And she goes back home, and lo and behold, turns out she was right. Because she goes back, works hard on being a better wife. He says, I love you, I forgive you, I'll never hit you again. Everything is great. For a couple of weeks, a couple of months, kapow, she's back at the battered spouse shelter. And this pattern just goes around and around and around, and there's no resolution. Because she's just either in approach, I love you, bond, connect mode, or I hate you, I'm out of there mode, back and forth, back and forth, back and forth. So this is how the problem of attachment of the perpetrator and the locus of control shift are all entangled and intertwined with each other. And the locus of control shift is a solution to the problem of attachment of the perpetrator. Because if you take all that negative energy, all that evil, all that not good, and you shift it inside you, and you're the problem, it's all your fault, now all of a sudden mom and dad are kind of sanitized and cleaned up, they're safe attachment figures. They're just running this tough love program on you because you deserve it because you're a bad little boy or girl. And once you become a good boy or girl, they'll see that and all the abuse will stop and everything will be fine. So when we're at the battered spouse shelter, we ask the woman, well, what was it like when you were growing up? So a lot of the time, but not all the time, she will have come from a trauma, violence kind of family. And so her story is, well, me and my sister would be playing in the living room and we'd lose track of time and all of a sudden, oh, that sound, that most horrible, frightening sound, Dad's car coming up the driveway. Is he going to be drunk? Is he going to be angry? We better tidy up. We've got to clean things up. And he comes. Sometimes he's okay. Sometimes he passes out. Sometimes he watches TV. This time he's really angry. And so the two little girls run and hide in the closet, and they hear Mom screaming and yelling. They hear some thuds and some thunks. Then everything gets quiet. They come out. Mom's in the kitchen crying. Dad's passed out on his chair. But where's his remote? Geez, we didn't get his remote back on the arm of his chair. We were too careless. We were playing. It got lost and went under the couch. We're never going to make that mistake again. So that little girl was already operating out of locus control shift. It's my fault. I was a bad little daughter. I stressed him out. If his remote had been where he wanted, he wouldn't have been so angry. Mom wouldn't have got hurt. It's all me. What I do is I run and hide in the battered spouse shelter. No, I hide in the closet. And then I come out and I try and figure out how to manage the perpetrator. It's exactly the same pattern 30 years later. Instead of running to the closet, she runs to the battered spouse shelter. Instead of going back to Dad, she goes back to husband. So it's completely unresolved attachment to the perpetrator and locus control shift dominating what she thinks, her perception, what she says, what she feels, and her decisions and where she lives in the present. It's not just a theory about her childhood. So that's problem of attachment to the perpetrator, locus of control shift. And then this I'm just going to touch on briefly because Melissa will expand on it in the afternoon. But the basic idea here is taken from family systems theory, which is a whole body of literature. Family therapists think in kind of a different way from regular therapists, psychiatrists, psychologists. And their thinking is systemic thinking. So the patient comes in, or the family comes in rather, and they know what the problem is. The problem is the teenager who's acting out. And if you're a non-systemic, non-family therapy, non-systems thinker, you're going to take that individual kid and you're going to put him on an assembly line. And you're either going to give him meds or give him psychotherapy or give him some combination of something to fix him. And the parents are just going to kind of wait over there and maybe come in once in a while to a session while you fix the problem inside the kid. Now, whether it's sort of a more Freudian idea about defense mechanisms or it's more biological psychiatry, brain chemicals, the problem is inside the individual kid. But from a systems point of view, that's not the way it is. The idea is that the behavior of the kid is actually solving some problem in the background. You got to figure out what's the function of this behavior in the family. What is it helping the family deal with or avoid? And then you figure out, oh, well, it's this. And then you might intervene with just the parents. So the treatment might not be for the kid at all. You might put the parents in marital therapy because the kid's just acting out the stress in the family. So the problem is not the problem. The presenting problem is a solution to a problem in the background. Melissa will go into that. Just say no to drugs is the 12-step part of the model. So we commonly have people who've been in AA or continue to be in AA, or we recommend they go to AA. But actually in the trauma program, we don't talk the lingo of the 12 steps that much. We do some, but nobody would say, well, this is obviously a 12-step program. But the basic idea here is that you have to say no to your drug. And what I'm talking about here is this core, deep down in there, commitment to recovery. And sometimes I explain it by saying, well, the 12 steps are good, but there's another step that doesn't get talked about so much, which I call step 0.5. Before you can work the 12 steps, you got to work step 0.5, which is you got to decide to work the steps. If you don't decide to work the steps, nothing starts. So what I'm talking about is just reaching down in there, making a for real, serious commitment to doing the work to maintain sobriety. There's no manual for that. There's no technique. There's no steps. Nobody can explain how to do it. Nobody can do it for you. You just got to do it. Or not. You don't have to. But if you want to go down the path of recovery, you got to make this commitment. So that's just say no to drugs. And in this way of thinking, as Melissa will go into in a lot of detail, everything is a, quotes, drug. So some drugs are just literally drugs or alcohol. Then there's a sort of broader definition of addictions, which includes eating disorders, gambling, sex addiction. So we've just broadened the definition of a drug to everything. So in this model, you can be addicted to a drug, alcohol, eating disorder, self-mutilation, a DSM diagnosis, a social role, being the victim, or you can even be, quotes, addicted to the locus of control shift because you're using it as a way to avoid something. So that's the problem is not the problem in a nutshell. And just say no to drugs. Then addiction is the opposite of desensitization, which Melissa will also deal with quite a bit. So I'll just give the basic idea here. So from this perspective, all addictions are avoidance strategies. They take you from here to over there. And sometimes they've got really big engines and they really make a lot of noise and they're really cool and they go really fast and they kick up a lot of dust and they're really exciting. Otherwise you wouldn't be addicted to them. So every addiction is a transportation vehicle that takes you from here to over there. Here is where you are now. Bad situation, bad feelings, bad memories, a whole bunch of stuff you don't want to deal with. And over there is anywhere except here. Distracted, passed out, stoned. So therefore all addictions are avoidance strategies. And again, we broaden the addiction model to cover everything. So you can be addicted to locus control shift, the victim role, on and on with all these DSM symptoms, diagnoses, and behaviors. Desensitization is the opposite of addiction. That's when you say no to your drug. So you're in good shape if you only have one drug, or your list of drugs. You turn around on purpose and step by step start facing and dealing with what you've been avoiding. And then we're going to go into all the treatment details on how this actually in reality rolls out. So addiction is the opposite of desensitization. And desensitization can be kind of divided into two broad categories. There's flooding, and then there's systematic desensitization. So if you didn't have anything better to do with your time and you decided to read the PTSD literature, you'd hear that the evidence-based treatments for PTSD include, there's a short list, but includes cognitive behavioral therapy, prolonged exposure, EMDR, and there's some variations on cognitive behavior therapy. Prolonged exposure basically means, like if you're a Vietnam vet and you still have PTSD, you sit there and watch Vietnam combat movies over and over and over and over, and then gradually you just de-escalate, settle down, and it doesn't bother you anymore. It's kind of an odd theory in a way, but it actually, there's lots of evidence that if you have just a one car accident, just one assault, so one adult trauma, and you just do this prolonged exposure where you imagine it, you talk about it, you do some breathing, do some grounding, you fairly quickly learn to be able to think about it, remember it, without having the full PTSD revved up, fight-flight response. That's good if you have one trauma. It's fairly simple, fairly clean. But if you've got massive chronic childhood trauma, you can't do prolonged exposure. If you just think about it, talk about it, think about it, talk about it, relive it, have flashbacks, all that happens is you get worse, you have more symptoms, you have more flashbacks, and then in order to cope with that, you got to do your addictions even more. So it's completely counter-therapeutic. So with complex trauma, it's all about breaking it down into little steps, step by step by step. Go into the feelings, whatever it is you're avoiding, deal with a little bit, back out, settle down, back in, back out, back in, back out. So this is why recovery takes more than 5 sessions. And then this is actually my last slide. And we'll take a break in a little while. So, anybody here with a PhD in mathematics? I'm guessing no. I don't have one either. So therefore, I had to keep this geometry simple enough that I could actually remember it and use it. So the basic idea here is a triangle has 3 corners. That's why it's called a triangle. Not too hard to remember. Mental health professionals forget this all the time. So what this is it's a triangle of what's going on in the person's life, of what happened in their childhood, and it's also a triangle of the therapy relationship. It's a good model because it's systemic. So there's 3 people, so that's a system. There's a perpetrator, there's a victim, so we're already in trauma language. And it's simple and clear enough that you can remember it and use it. So from the treater's perspective, what we want to do is not be on the triangle. So we don't want to be walking around gnashing our teeth about how we've been victimized by the clientele because they're acting out so much and causing so much trouble, because then we're just all wrapped up in being the victims and therapy disappeared. We don't want to be in the perpetrator role where we're being rude, mean, cruel, dismissive, belittling to the clientele, because then we're just in the perpetrator role and we're just redoing the trauma that they're trying to get out of. We don't want to be the rescuer, so we do and we don't want to be the rescuer. So obviously, we got to be doing some kind of, quotes, rescuing, otherwise we're of no use whatsoever. But we don't want to be in the rescuer role where we're making the person be completely dependent on us for survival, for sobriety, for recovery, for whatever it might do. Because then we're just recreating this little dependent child. Now you've got the rescuer good parent who's come in, life is great, but how are you going to grow up and learn how to be an adult if you're always dependent on your rescuer mental health professional? So you can be, so this is all a matter of balance and degree. So say we're talking about, what's the term for that again? The chemical event, I'm not going to be able to remember, but I think you guys might know. So when you have not a coach, but somebody who's with you 24/7, monitoring your sobriety, who's been hired to do that, there's a name for that person, I can't remember what that's called. So that's kind of a rescuing role, where you're just not able to stay sober. That's okay for some kind of period of time, but not for the whole rest of your life. So it's kind of some rescuing behavior is inevitable, that's what the field is for, but not too much for too long. So in an inpatient setting, people frequently are in the victim role. So they feel like they're victims and they take that role and they do it too much. Or they can get into the perpetrator role and then they're perpetrating against other people in the program. We have to do something about that. Or they can be in the rescuer role too much, where they're spending all their time supporting, helping out the other people in the program as a way to avoid their own work. So there's nothing wrong with being helpful, but if you do it to such a huge degree that you're avoiding your recovery, that's a problem. So then we go back to the problem is not the problem. Okay. The problem is you're in the rescuer role. But what problem are you solving for yourself temporarily by being in the rescuer role, or the perpetrator role, or the victim role? So we kind of use this to track the dance of recovery. What's our role? What's the person's role? What triangle are they stuck in? What are they reenacting? And there can be 1, 2, 5, 10 different triangles going on all at the same time, and they can spin around and switch. So the person can be in the victim role, and then next day or next hour, they're in the perpetrator role. So if we're talking about somebody with a childhood sexual abuse history, who's now a sexual perpetrator as an adult, they're in the perpetrator role because now they're in charge, now they're making it happen. They're no longer the victim, everything is good. Except they're just on a treadmill of constantly having to be the perpetrator in order not to feel all that unresolved victim stuff. So there's no healing or resolution. Just like if you get drunk, everything's great, you don't have to feel it, you don't have to know it, you don't have to think about it until tomorrow morning. And then it's all back there, and then you've got to do the addiction over and over. So it's the same with being in the perpetrator role. It gives this temporary sense of power, control, and mastery, but it's only temporary, then it crashes, then you got to do it again. So we just use this lingo to track what's going on in the therapy relationship, what's going on in the person's outside relationships, and how does that fit with what was going on in their childhood. And as I said, that's it for slides. So now for the rest of the morning, we'll take a break here in a little bit. It's going to be me giving you examples of how I work, what I do, what my approach is, what I think of. So if you were at one of the trauma programs, you'd get a group schedule. And you would see on the schedule that there's about 30 hours a week of groups and 3 hours a week of individual therapy, plus the psychiatrist does rounds and checks your meds, and then there's a discharge planning, all the usual stuff that happens. But the part that's not usual for a general psych hospital is there's a whole lot of for real intensive psychotherapy going on. And without that, I don't really see exactly the point of a lot of admissions other than just kind of a timeout and de-stress a little bit, a couple of med adjustments. But when you're looking at general adult psychiatry these days, where the average length of stay is like 5, 6, 7 days, it's not enough time even for the med changes to start having any effect. So we have a little bit longer length of stay and a lot of active psychotherapy. We don't have long length of stay in our programs because they're basically managed care Medicare programs. So the maximum length of stay inpatient is 3 weeks. You can go to the partial program for up to 4 weeks. So that's the clientele that we serve. But if you stay as an inpatient for 2 weeks, you actually get 60 hours of group, 6 hours of individual therapy, a whole bunch of structured homework assignments. So you can literally cram in like a year of outpatient psychotherapy in a couple of weeks. So therefore, we see a lot of change. And if we have a thing called the Visiting Professionals Program, where professionals can come and watch the groups and sit in on team meeting. So if you either were a patient or you were a visiting professional, you'd notice that there's several different types of groups. There's sort of general educational groups where we teach the model as a kind of lecture. There's general process groups where just what's going on with you currently, what are your goals? So no different from a general process group. And then it's kind of half cognitive behavioral and half experiential. And what I'm the guy for is the cognitive behavioral part. So when you listen to me explaining how trauma model therapy works and how the program works and what I do, you're going to think, hey, this is all cognitive behavioral. Well, that's because it's just me talking. When you listen to Melissa, who, not currently, but before she did a lot of art therapy for many, many years, it's all clearly not just cognitive behavioral, it's much more experiential. So we have a variety of experiential groups which are directed towards anger, fear, sadness. So in different groups, we have different things going on, and we're focused on different feelings. Why do we have experiential groups, such as anger management? Well, not just because it's nice to feel your feelings, not just to blow off steam, which is part of it. But really what this is two things. It's systematic desensitization, and it's a sheltered workshop where you actually practice how to cope with your feelings. So it's not just an intellectual exercise. Okay, class, What are we going to do when we're at home when we feel angry? Oh, I'm going to tear a phone book or go for a walk. Okay, nobody tears phone books anymore because nobody has them. So you can have a list of strategies that you can use, and that's handy, that's good. But how about actually practicing it? Not just intellectually, but with the feeling actually up and running. So we have this group set up that I'll describe a bit, where we get the anger up and running. So you're actually feeling it and expressing it. Why do we want to do that? For two reasons. You get the anger up. Okay, that's good. Now what? So you can't go and do your addiction. You can't act out. So you got to figure out how to de-escalate back out and settle down without acting out. So this is actually a sheltered workshop opportunity to practice dealing with the feelings in a healthier way without acting out, which you can't do unless the feelings are up. The other thing is the desensitization. Okay, so the anger management setup that we have is this throwing balls of clay at a board, which is just one way of doing it. And it's not very good for a private office outpatient practice because it's too noisy. But if you're in an inpatient or a residential treatment center, you can do this. So you start throwing balls of clay at a board, start getting a little heated up, put some muscle into it, and then you start yelling at whoever you need to yell at or whatever you need to yell about. Okay, the anger's up and running, you're actually shouting, you can feel the energy, you're in fight mode. And what's the reaction you're getting? Bizarrely, you're getting this reaction of, good work, nice job. You really did a nice piece of work there. So you get all this positive feedback, you back out, you settle down, you don't act out, there's no negative consequences. So now you go, hey, wait a minute. When I was a little kid, that anger was just gigantic and huge and overwhelming. And if I expressed it, nothing would happen except getting beat up. So I had to stuff it. It was too dangerous. My own anger was bad, wrong, and evil. And I stuffed it. But now it turns out I'm not this tall, I'm this tall. So when I look at this big ball of anger, it just looks a little smaller from a grown-up perspective. So that's a little bit of desensitization right there. You're just changing, reframing, changing your thinking. This anger's not quite so unmanageable, not quite so huge. I'm taller and bigger, I've got supports, I've got a driver's license, I'm not living with the perpetrator now. Hey, I don't have to be quite so overwhelmingly scared by the anger, therefore I don't have to so desperately avoid it through all my behaviors and addictions. So there, we've got a little bit of desensitization. You back out, you settle down, you go into it a little bit further this time because you're not quite so afraid of it. Back out, settle down again, and then you start to learn, hey, it's not as overwhelming and scary. You've practiced your management skills, and now it starts to become conceivable that maybe sometimes you could just feel angry or sad or scared and not have to run over to your addictions. So that's basically, I'm making it sound simple when it's actually complicated and painful and difficult, but that's the basic ideas. Okay, so as I mentioned, if you want to ask a question, that's fine at any time. And I'm going to now give examples and try and show how all these different elements are intertwined. It's sort of like if you go around this loop, you come back to attachment to the perpetrator. You go around here, you come back to locus control shift, and it all is intertwined. And I remember there's all these experts in the field. So I remember watching one particular guy who's very cognitive behavioral, and he talks about cognitive behavioral and makes it sound like very middle of the road and kind of rigid. And then he showed a tape of himself doing therapy, and he was just talking to the person. And then I remember watching another guy who was more kind of Freudian psychoanalytical, and then watching him do a tape of therapy, and didn't look that much different from the conversation the cognitive behavioral guy was having. So if you read the literature, you hear about these kind of rigid categories of treatment as if they're all very distinct and different. But I think in reality, a lot of people do fairly similar stuff, And it's not just one rigid model, kind of borrow a little from here, a little from there. But this trauma model therapy is integrated within this overall conceptual scheme. But the more tools in the toolbox, the better is my philosophy. So I could draw on this, or draw on this, or draw on this, or draw on that. But as I forewarned you before the break, you're going to get fairly cognitive behavioral sounding approach from me. So in the inpatient setting, pretty much since everybody's either managed care or Medicare in our programs, these days you've got to meet what's called inpatient acuity criteria, which means if you're not severe enough, the insurance company's just not going to pay for it. You can't get in. So the acuity criteria threshold has been climbing and climbing over the last 20 years. So basically, you have to be pretty suicidal, pretty homicidal, or so disorganized you just can't even do everyday functioning in order even to get into an inpatient unit. So by and large, it's a kind of suicide program. That means that we have a lot of people who've attempted before, attempted immediately before, or are thinking very, very seriously and have a high level of intent of either overdosing or whatever the method might be. And it also means we have a lot of people who cut and self-mutilate a lot. So that's a program focus all the time, week in and week out. So it'll be dealt with in all these different types of groups. It'll be dealt with in individual therapy. The group that I do is called Cognitive Therapy Group. And the setup is, if this was a group, I would explain how the group operates, and then I would work with one person. And that person is selected by kind of a combination of they request it, the staff says this person should work, and taking into consideration discharge dates. Because if there's two people who want to work, and one's not going to be discharged to next week, and one's going to be discharged at the end of this week, then I'll work with that person. And the introduction I give to the group is, I'm Dr. Ross. This is Cognitive Therapy Group. In this group, one person at a time does some work. And the idea is while that person's working, everybody else is kind of processing along. Because what the person's working on probably will have something to do with why you're here and what you're working on. And we can deal with anything at all. The only thing that we don't get into is details of trauma, because they're too triggering. So we leave the details for individual therapy. Here we refer to the trauma in kind of general overall terms. And the basic idea behind cognitive therapy is I focus on how your thought patterns are affecting your feelings and behavior. And could you tell me your name, if I don't know it already? And then we kind of launch into it. And so that is the basic explanation of the group. And then I'll spend 5 to maybe 10 minutes finding out, besides what your name is, where do you live? Who do you live with? How's that relationship going? Are you married? Do you have kids? How are the kids doing? Where did you grow up? Got brothers and sisters? How many? How much contact with them currently? Are your parents still alive? Are they married or divorced? Remarried? What's your level of contact with all of them? How does that go? What's your job history? A little bit of detail on who your perpetrators were and what the types of trauma were. And then any other major events that happen going along in life. And then a little bit on what are your goals for the next short term, medium term, next 5 years, where do you want to be in life? So I get all of that in kind of capsule form because I'm not just working in a vacuum. I want to work inside the person's life story. And the reason I want to do that comes back to kind of the general basis of the model. So I went to medical school. So as a medical student, I took medical histories and wrote down, there's a format for it, and then I would do physical exams and look in people's ears and so on, and look at the lab values. So that's writing a medical history. And when you then go into psychiatry, you kind of copy the format. You're the doctor, you take the history, it's divided into sections, and then there's a diagnosis, and then there's a treatment plan. I also have written short stories and a variety of different other kinds of literary writing. In my view, having done both, it's not really taking a medical history that's so important. You do get the person's story, but it's more like writing a nonfiction short story of the person's life. To me, that's what history taking is. Who is this person? Where'd they come from? What have they been through? And how do the symptoms, the diagnoses, the behaviors, the addiction fit into this person's life story? So it's very different from, they're walking along, they're doing fine, and all of a sudden their brain goes on the fritz and they develop a disorder. It's very much, what's the story? How does this fit in? What's the survival purpose of this? And we're normalizing all the time. So I commonly will talk about anger, which I talked about a little bit before, and then I'll talk about the fight-flight response. And I'll actually do a little mini workshop with a person on, okay, so you're a mammal. What do we know about mammals? We know if you threaten them, they're going to have one of several responses. They're either going to go into fight mode, they're going to go into flight, or they're going to go into freeze. So if you try and corner a grizzly bear and beat him up, he's going to come back at you in fight mode and you're going to lose. If you try and corner a gazelle, he's going to go into flight mode and run away, and it'll be faster than you can chase him. If you start bothering an opossum, he's likely to curl up in a ball and go into freeze response. And human beings have the ability to do fight, or freeze in different combinations in different situations. And so all this anger that you've got inside, that's the normal mammal threat response system that's been activated there. Anger equals the fight mode, fear equals the flight mode. So the reason that you have anger inside you is literally because you were a threatened mammal over and over and over and over and over. And the threat could be physical attack, sexual attack, or it could be abandonment, because that's a very threatening, scary thing. And if you're down here at this kind of height and you're totally, completely abandoned by all adults, it's just as lethal as being attacked by a mountain lion. You literally die. So you may literally be under life-threatening threat, and the threat is there's nobody there. Or if it's not literally life-threatening, it sure feels emotionally life-threatening. So therefore, you're going to go into fight, flight, or freeze. So we teach these things, we normalize it, that the anger in and of itself is it's not bad, it's not evil, it's not unnatural, it's not a mental health symptom. Of course, it is a problem because you're acting out angrily in all these ways. And it's also kind of hard and distressing to feel all that. But at the core, basically, fundamentally, this is unavoidable, completely normal mammalian response. Now the question is, okay, what are we going to do about that? So we're always normalizing the symptoms, the diagnoses, the feelings, the behaviors, putting them into this life context and seeing how this makes sense for this person in this life story, as opposed to this opposing model, which is you're just walking along and all of a sudden your brain's on the fritz and you have a disorder. So we're in the group, and now I've got the story, and why are you here is one of the questions I always ask. I'm here because of, and it could be self-mutilation. Oh, okay. So I read the book that I wrote, so I already know what the model is, so I'm right away going, okay, there's going to be locus control shift in here. And there's going to be the problem is not the problem. And so since I did write the book, and since I've done this over and over and over and over, it's kind of pretty second nature. But it's not that difficult for like an intern who comes into the program, works with us, to learn and use this stuff, because it's boiled down to these basic ideas. It's not like there's 420 ideas.
Say a patient is like hypersensitive, has their heightened senses getting in the way of relationships, what form of therapy would best suit them?
So the question is, if the person's hypersensitive, overreactive, that's affecting their relationships, what type of therapy? So the thing about, which is a very good question, which I'll bet you'll get more answer from Melissa this afternoon than you get from me. But basically, this trauma model therapy is a very general model that's useful for everything and anything. So there might be like a slightly different focus, or you might pull these things out of your toolbox, but it doesn't really matter what the addiction is, what the problem is. We're always using these basic principles. Okay, so in this instance, the person's oversensitive and overreacting. So right away, I'm going to come back to self-mutilation in a second, but right away I'm going to be thinking, okay, how did that person get to be oversensitive and overreacting? I'll go back to the story of the childhood. Well, that's going to make somebody oversensitive and overreacting. So I want to normalize it, fit it into the story. But just because it's an understandable reaction doesn't mean it's healthy or good or not distressing. But I want to have this foundation of, okay, this is just how human beings react. There's an extreme situation, therefore we have an extreme reaction. And then I'll want to look at, okay, the problem is not the problem. What problem is being solved for this person? Maybe not in the healthiest way, but what problem is being solved by being oversensitive and overreactive? And I'm right away going to be thinking, okay, so there could be the odd person who's just born oversensitive. But even if you're oversensitive by temperament, if you grow up in a healthy family, you're just kind of a little more sensitive. So you might be a little more artistic or a little more touchy-feely. It's not going to be a mental health problem. So it's usually an interaction of the person's got a little bit more of a sensitive temperament, and then we throw in all the trauma, neglect, abuse, whatever it is, and then we get too much oversensitivity. But assuming then there's, because some people just aren't sensitive, right? But if you're a little over on the oversensitive side, then you have whatever mix of trauma, abuse, neglect, then you get way oversensitive. First of all, that's understandable, but that's not going to happen unless there's some sort of upsetting, threatening, scary relationship stuff going on as a kid, right? So then my first theory is going to be, I wonder if, and these are all I wonder ifs. It's not like, I'm Dr. Ross, I know for sure. But I'm fairly confident that I'm sort of on track. So I wonder if being oversensitive is a way of self-protection, because if you're too sensitive, you pull back, you don't take too much risk, you don't get too attached, so therefore you're protecting yourself against future hurt, disappointment. And then I'm going to be thinking, okay, so there's probably locus control shift in there. And then I'm going to be into my trauma model elements. So that's kind of like a partial beginning answer to your question. So let's cycle back to that as we're going through all these examples. Is that okay? Okay. Oh, the more questions, the better. Don't worry about throwing me off track at all, because it all kind of fits together.
Okay, so you were talking about the emotions associated with fight, flight, and freeze. So is there an emotion that goes along with freeze? Because anger is fight.
So now you're asking, what are the emotions that go along with fight, flight, or freeze?
Right.
So fight's obvious, it's anger. Flight's fear. Freeze is more, which Melissa will go into in great detail, more of the numbing shutdown.
Okay.
And there's a whole other section to this, which is the biology of the sympathetic system and the parasympathetic system. There's a whole interesting big thing that we're not going to talk about that much, but Melissa will touch on that. Okay. And if you look at the criteria for post-traumatic stress disorder in the DSM, which have sort of evolved and changed from 1980 edition, 1994 edition, 2013 edition, but there's an up pole to PTSD, which is hyperarousal, scared, danger, flashbacks, nightmares, and then there's the shutdown, numbing, avoidance, denial. So that's going to be more the freeze response. It's going to be more the parasympathetic nervous system. This up pole is either you're going to go into fight mode or flight mode, and it's more the sympathetic system on override. So.
Now, how can a person tell if they have PTSD?
How can you tell that you have PTSD? In any mental health problem, whether it's depression, substance abuse, PTSD, you can either have a little tiny whiff of it, you can kind of have sort of a medium amount that's starting to get to be kind of a problem, but it's kind of manageable, and then you can have like almost the official diagnosis, and then clearly the official diagnosis. So it's all kind of on a spectrum from mild to moderate to severe. So if you have like full-on PTSD, it's just a matter of walking through the checklist of symptoms. So part of the definition of PTSD is there has to be some kind of traumatic event that took place. So you can't have PTSD because nothing happened. So then it's either a car accident, physical abuse, molestation, combat, and there can be a whole pile of different events. So there has to be some identifiable event that it's all kind of tagged to. So then you have to go, oh, well, that's what happened that's troubling me. And then the symptoms are this kind of checklist. So you've got flashbacks, and you can have different combinations. You don't have to have all of them. And depending on which disorder, you have to have, you know, like 2 of these or 3 of these or 5 of these. But so the up-whole symptoms are the flashbacks, the nightmares, hyperarousal, your heart rate's up, you may be sweaty, you're looking for danger, you're scanning, you're easily startled, and you get triggered. So if it's a Vietnam vet, so I've worked with Vietnam vets in the last 5 years who have full-on active PTSD from what happened 40 years ago. And so the typical thing they'll experience will be, or the example I use is they're in the backyard barbecuing 30, 40 years later, everything's fine, they feel normal. The news helicopter goes overhead, all of a sudden, whoosh, giant flashback, they're back in the combat, they see it, they hear it, they smell it. The guy dives under the bush, he's totally disoriented. And all his family members have to say, it's okay, you're here, you're in the backyard, it's safe. And then he kind of gets grounded and comes back. So that's a huge flashback with a trigger. So you can get triggered. So if you're a woman who was sexually abused by Uncle Joe, who always wore a blue baseball cap, you could be walking along feeling totally normal, and an adult male with a blue baseball cap walks by, and you go into fight, flight, freeze. So that's the up-pull symptoms. And they're sort of emotional, psychological, and physical symptoms all together. And then, as I said, there's the numbing shutdown. So if you tend to go into literally freeze mode, where like you're kind of frozen for a little bit in response to a trigger, or more commonly you're just kind of numbed out, shut down, no feelings, on automatic pilot, and you withdraw behaviorally. So like the big version is the vet who lives in a cabin in the woods 20 miles away, is completely physically withdrawn. But more commonly, you're at home with your family, but you're just in the video games, just watching TV, just drinking. You're not really connected, you're not interacting. And for combat guys, the family commonly says, he went over to Iraq, Afghanistan, he physically came back, but the person we knew never came back. So you're like your whole kind of psyche, self, energy, spirit is numbed out, shut down inside as a self-protection. So it's just, do you have that not at all, a little bit, quite a lot, or that's really a big thing? Okay. So coming back to the group with the self-mutilation here. So there's one fly flying around here, so I may every once in a while be whacking at it. So the person comes in, and the reason they're here is either they have been cutting or they were just about to cut. So people that self-mutilate, cut on themselves, there's people who do it like a few times in their whole lives, or just do it like a couple of times as an adolescent. That's sort of a different category. The people that we work with mostly have done it quite a lot for quite a few years. And they kind of subdivide into 2 groups. There's one group that actually feels the physical pain, and that's good because the physical pain distracts them from the emotional pain. But pretty solid majority, this is people who know how to dissociate well. So if you were a classmate of mine in medical school, you would have sat with me watching an amazing video of a woman having her gallbladder taken out with no anesthesia whatsoever, solely with hypnosis. She's perfectly calm, her pulse is normal, she's not sweaty, she's feeling no pain, and the guy's taking her gallbladder out. So these highly dissociative, highly self-hypnotizable people can block out pain really effectively. And so often they don't feel any physical pain at all. So then what's the purpose of it? So rather than going to a textbook to find out, I asked the person. So I want to know, okay, and I just ask, why do you do that? What's the purpose of it? And over and over and over, the answer is, basically, I'm feeling really lousy. There's all these bad feelings, bad situation. It builds up, it builds up. I try this coping strategy, that coping strategy, and after a while, nothing's working. It just gets to be too much. And then out comes the razor blade, and whew. So for chronic self-mutilators, it's exactly like shooting heroin. I mean, it works fast. All the bad feelings are gone. It's kind of warm and fuzzy. I'm going to be able to make it through the rest of the day. Life is manageable. I'm not overwhelmed. So people don't self-mutilate just because there's nothing on TV. I mean, it has a purpose. And if you do it over and over and over, that's because it actually works very effectively. So for instance, if you use alcohol excessively, nobody would have a few drinks before they go to a party if the alcohol made them more self-conscious, more anxious. Nobody would do that, right? The only reason that people would have a drink is because it actually does work to sort of lubricate the situation, calm the anxiety down, and hey, the world's a great place and everybody likes me and I like everybody. So none of these things would be addictive if they didn't actually work. Same with self-mutilation. Okay, so she explains that to me. I go, okay. And now I'm thinking, okay, I've got the problem is not the problem clarified here. The actual problem is the intolerable feelings in the background. The cutting is just the solution. It's unhealthy. We want a person to have a healthier solution. But really what we want to focus on here is not the diagnosis or the particular addiction. So our treatment in a way isn't really about the diagnosis. It's really about the problem in the background. So if somebody comes in with an alcohol problem, it's not like we don't notice that. Or if they're clinically depressed, we don't go, it's not important. We notice all these things. We certainly talk about them, but really the focus is on what's going on in the background. What's this problem solving? If you can learn how to solve the problem in the background, now maybe you can let go of the unhealthy coping strategy. And that applies no matter what the type of addiction might be. Okay, so then to really figure out what is the purpose of the cutting, I just ask, but I also do what I call the what if cascade, which is a whole series of questions. What if, what if, what if? So I'll just launch into that. Okay, so just hypothetically, what if all the feelings built up, it was overwhelming, it was too much, and you didn't cut? Well, that's impossible. Well, I know, it's just a hypothetical. Well, then I'd have to get drunk. Well, what if you didn't get drunk? Well, then I'd have to, whatever the next thing would be. So what if you didn't act out in any way whatsoever? That's impossible. Well, it's just hypothetical. Well, okay, if I didn't cut, and I didn't get drunk, and I didn't act out sexually, well, I'd have to kill myself. So from asking these questions, I found out something that was completely the opposite of what I was taught in psychiatry. I was taught in psychiatry, way back in the last millennium there, by people who knew nothing about trauma, that people who cut and do minor overdoses and so on, it's a attention-seeking behavior. It's not legitimate. They're not really suicidal. They're just trying to yank your chain. And it's not like a real serious disease like depression. Now, people who have the real serious disease of depression, they legitimately are suicidal and they legitimately might kill themselves, and you got to treat them to prevent that. But these people over here, borderlines and so on, they're just goofing around and manipulating, and they're not actually suicidal. So all the self-mutilation and so on was a suicidal gesture or parasuicidal behavior. It was fake, phony, weak, not legitimate suicidal behavior. That's the attitude I was taught, which first of all is a very ugly attitude, but it's actually mistaken. It's logically speaking, it's a category error. These aren't weak, phony, feeble imitations of real suicidal behavior. They're suicide prevention strategies. It's a completely different category. So I figured that out. Okay, so I'm going to define killing yourself as a form of acting out. So what if you didn't drink, sex, drugs, eating disorder, and you didn't kill yourself? And then they're going to say one of a couple of things. I'd get lost in it forever. I'd go permanently insane, something along those lines. And then I'll launch into, so first of all, okay, now I know what the problem is. So if there really was only these two options, and that's it, you're either going to cut on yourself or you're going to kill yourself. Well, okay, so I'm going to vote for cutting on yourself every time. It's completely rational, it's logical, you analyze the situation, and you make the correct decision. So so I'll say that out loud, or I'm thinking it. So I've just reframed the person. Instead of this wild acting out all over the place person for no good reason, this is a rational human being, and what they're really doing is self-soothing, self-care, and self-management. Not exactly the healthiest, could use a little tweaking on the strategy, but normal member of the human race, a mammal with threat response systems that have been activated that are still on when they don't need to be. So that's all the normalization. And a smart person, because if you were feeling so overwhelmed with feelings and your solution was to eat a little bit of Jell-O, that wouldn't work. So you choose something that actually works. Shows you're smart, dedicated to self-soothing, self-management. Okay, so that's all good to know. But let me explain a couple things here. And I'll explain them by asking you. Okay, so have you ever known somebody, so it seems like I've lost track of the conversation, I've changed the topic, but I actually haven't. Have you ever known somebody who woke up in the morning and they laughed every second of the whole day out loud? They went to sleep, woke up the next morning, laughed the whole day? No. How about somebody who was just angry, yelling, full on, every second of the whole day, every second? No. Well, so how about somebody who was crying, sobbing, tears coming down their cheeks, and it lasted all day and all the next day without a break? No. Okay, so this is not how the human body operates. So let's use the example of a panic attack, which can have all different sort of shapes and sizes. But a typical panic attack is you're going along on a scale of 0 to 100. You're maybe at 0 or you might be at 10 or 20. And all of a sudden, either because there's a trigger or out of nowhere, the anxiety spikes up to 100. How long does it take to spike up to 100? It doesn't take 3.5 years, right? You can't have a panic attack that builds over 3.5 years. It normally takes seconds, possibly a minute or two. And then how long do you stay up there, typically? Not 10 years. Minutes, maybe, usually not seconds, usually minutes, but usually not hours. And then it starts to kind of come down. And how long does it take to come down? Not seconds, not decades, minutes or hours. And then you may come back. If you started at 0, you may come back to 0, or you may only come back to 20. So that's a typical shape of a panic attack. So the reason I'm making this point is, actually, if you didn't cut, you didn't get drunk, you didn't act out sexually, you didn't kill yourself, the worst that would actually happen is you'd feel lousy for a while, and then it would ease off. Oh. So in cognitive therapy terms, this is called decatastrophizing. Because the catastrophe is, I'm going to get stuck in the feelings, I'm helpless to do anything about it, I can't fix it, I can't escape it. Sound reminiscent of how things were when you were a little kid? When you were a little kid, you were actually stuck in it, you were actually helpless, you actually couldn't fix it, you actually couldn't escape it. And now it feels like I'm in that reality again. But actually, in fact, if you do nothing whatsoever, the very worst outcome is you'll feel lousy for a while, and it'll ease off. And since I work with people who are highly dissociative a lot, hey, aren't you pretty good at dissociating? Use your dissociation skill to put it on the back burner a little bit. And the person may go, well, I thought I'm here for treatment of my dissociative disorder. Well, you are, but your ability to dissociate is a skill. If you can use it in a fluid, flexible, healthy fashion, that's great. The problem is you use it too much, too often, in a triggered, kind of out of control fashion. But in and of itself, it's a skill. So now I've just changed the whole project. So before, the project was, I'm going to try to do the completely impossible, which is tolerate these feelings without acting out, without cutting, which will result in going permanently insane or being stuck in it forever. You can't win that project. That leads to nowhere, but I got to cut. But if the project now is, hey, I could feel really lousy for a little while and then it would ease off if I did nothing, that's a doable, possible project that you could get to work on. So this is all reframing. Decatastrophizing means you're in this thinking pattern of it's a huge catastrophe, you reevaluate it. Well, it's not that big a catastrophe. Maybe I'm older than I thought, maybe I've got more skills. Oh yeah, I worked in anger management group and I didn't cut on myself after that. Okay, so that's good. Well, Dr. Rossi, you think it's so easy? I never said it was easy. This is why I like being the doctor, not the patient. It's easy for me to say, it's not so easy for you to do. But the basic idea is actually simple. You just say no to the drug of cutting. You make this commitment to sobriety from cutting, and then you get to work on it. And you're not as small, powerless, helpless, trapped, overwhelmed as you have been rating yourself. And we've just practiced it several times over the last week or two that you've been in the program. You have more coping skills than you thought. So maybe it's conceivable that you have what it takes to get through life without cutting. And the person's, whoa. And people will commonly go, it's sort of like the eureka moment. They'll actually say, I never looked at it that way before. Wow, that really makes a difference. And so it's not just this kind of like Mickey Mouse making suggestions. It's actually a pretty big revolutionary shift in the person's worldview. Problem solved? No. Okay, so now we got to look at the other aspects of the self-mutilation. So I'll say, okay, so if you did nothing, nothing would happen. Except you feel a little bit lousy for a little while. Oh yeah, easy for you to say, but I don't know how to do that. Well, there's no how-to about it. You just don't cut. And so, oh yeah, that's easy for you to say. I'm not strong enough. Okay, or it'll be I'm not strong enough, or I don't know how. It's going to be back and forth between those two. So I don't know how. I have to, then that goes into I've got to work on my recovery more, and I've got to get more tools in my toolbox, and then when I have the coping skills, then I can stop cutting. Okay, and how long are you thinking that's going to take? I don't know, months. Okay, so right now in this moment of time, you're actually, I'm talking about self-mutilation. I could be talking about alcohol or drugs, sex addiction, eating disorder. Right now in this moment of time, you're not in crisis, you're not overwhelmed with feelings, and I'm asking you about your policy. And your policy is, you're not going to cut today. Well, that's easy. You're in an inpatient unit, you don't have any razor blades, and anyway, you're not overwhelmed and nothing's happening. So, but I'm asking about your commitment long term. And people can give kind of one of two answers. So let's shift over to AA for a second. So we're at an AA meeting, and one person says, I'm working my recovery one day at a time, which is a very good motto. But what does that person actually mean? What they actually mean is, I'm on it today and tomorrow and every single day. So what they really mean is I can't like take a week off. I'm working my recovery one day at a time, every day, ongoing. Good. Next person says, I'm working my recovery one day at a time. What does that person actually mean? They've created a little out for themselves. Hey, I never said I was going to be sober 2 weeks from now. I just said I'm going to work one day at a time and I'm not going to drink today. So it's the same words, but they're giving themselves an out clause because they never made a commitment to not drinking next week or the week after because they're working one day at a time. So they're using that as this kind of self-deception sort of scam they're running on themselves. But really the policy in the present is I'm not serious about not drinking next week. I'm only serious about not drinking right now. And I'm actually holding it open as an option in case I need it in the future. So right now the policy is I'm not going to drink today, but if I need to down the road, I will, because I'm only committing to one day at a time. So it's a very different level of commitment to recovery, and it's a very different policy, and it leads to a different behavior, because the one person doesn't have any alcohol in their home, and the other person has a flask of whiskey tucked in the back drawer, just in case they need it 2 weeks from now. So when we're back to the self-mutilation now, okay, so you're telling me that you have to wait for months and months and months and months to get enough tools in your toolbox or do enough recovery work, or you're not feeling so bad, or the situation is fixed, and then you can say no to cutting. So right now, you're just not strong enough, you don't have enough skills. Right. So you're how old? 36. Okay, you're 36, and you've survived one abusive marriage and one abusive long-term relationship. You survived all that physical abuse, family violence, sexual abuse as a kid. So when you were this tall, you survived all of that, and now you're telling me you're not strong enough to stop cutting? You've completely disproven this theory of yourself by surviving your own childhood. Only an incredibly strong, courageous survivor person could still be walking around speaking the English language. So you're telling yourself a negative myth about yourself that you're not strong enough in order to hold on to the option of self-mutilation. But it's not even factually true. It's disproven by what you've already survived in life. Only a strong person could survive that. And it's handy if we're talking about self-mutilation, but the person's never used cocaine for the last 7 years. Because then I can go, you've already said no to one major addiction and been clean from that for 7 years. So again, you've already proven that you can say no to a major addiction. So you're just holding on to the negative myth of I'm not strong enough, or I don't know how. And the person goes, geez, I hate cognitive therapy. It's also known as painting them into a corner therapy. So we're trying to take away all the rationalizations. And the rationalizations we're taking away are basically negative beliefs about yourself that aren't even factually true. But it's handy to have the negative beliefs about yourself if you don't really want to stop because you can't, because you're not strong enough. So there's all these rationalizations all the time. But then I really want to get kind of the nitty-gritty of it, which is the locus of control shift. And how do I know the locus of control shift is involved? Because I read the book that says it is. So how am I going to kind of get into this? So the locus of control shift equals self-blame, self-hatred, self-punishment. So I know there's self-blame, self-hatred, and self-punishment because the person's cutting on themselves. It's literally self-punishment. So I also know that there's got to be some rationalization for why it's okay to cut on yourself. And what's it going to be? Well, I already know in advance, but I have to ask and draw it out of the person. So it's most powerful if it's a 30-whatever-year-old woman who has a 12-year-old daughter, because then it's like, whew, really powerful. But if not, it's a niece, or it's just a hypothetical little girl. But if it's your daughter, then we're really in it. Okay, so what if your daughter came home from school and had like the worst day ever? Lousy grade, got chewed out by the teacher, bullied on the playground, the guy she's got a crush on ignored her or said something mean to her. She comes home and says, Mom, could you just teach me how to cut? What would you do? Absolutely no way. Okay, so what if she already was starting to experiment with cutting? Would you show her better techniques of cutting? Would you buy her a supply of razor blades? Absolutely no way. Would you do everything in your power to get her off the self-mutilation track? Get her to therapy, find out what the trouble is? Yeah, absolutely. Why would you do that? The person's like, what do you mean, why would I do that? Was it fair to say that you do that because you love your daughter? Right. Well, what does your daughter have to do to earn your love? Nothing. So you love your daughter unconditionally. She doesn't have to earn it. And she deserves to be treated decently with love and respect by others and by herself. And if somebody, in this instance herself, is treating herself in a hostile, negative, destructive, angry way, you're going to try and do something about that. Right. Right. And what's the difference between you and your daughter? How come it's okay for you to cut on you and not okay for her to cut on herself? Wait a minute. Are you telling me that if I love myself the way I love my daughter, I wouldn't cut on myself? That's exactly what I'm saying. So you have to hold on to the locus control shift. You have to rate yourself as a bad little girl, slime, evil, not a member of the human race, undeserving, unworthy. You have to hold on to that belief to justify cutting. If you really, 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 really let it sink in that you didn't cause all that abuse, you didn't deserve it, it wasn't your fault, you deserve to be loved and cherished like every other kid, you wouldn't be able to cut it yourself. You just wouldn't do it. Now I see what you're saying. So your actual addiction is not to cutting, it's to the locus control shift. So when do you think you might say no to the drug of the locus control shift? I don't know how. I'm not strong enough. Okay, we already went over that. So this is showing how the cognitive behavioral locus control shift part of it kind of operates. So then any question about that or comment or thought? So now if, let's say the problem is an eating disorder. Where's my drink? Oh, here. So now we've got a completely different problem. So in the mental health field, the way it's divided up is you've got the DSM. And the DSM's got different sections to it. So there's eating disorder section, PTSD section, schizophrenia section, and then you've got different books. So here's a book about schizophrenia. Here's a book about eating disorders. Here's a book about borderline personality disorder. Here's a journal that specializes in psychosis. Here's a journal that specializes in eating disorders. How do you know? Because it says the Journal of Eating Disorders. And then there's a conference, and here's the brochure, and it says the latest treatment techniques for eating disorders. And the people who are speaking at the conference are the people who write the books and the papers about eating disorders. So you go to the eating disorder expert, and you find out how to treat eating disorders. Or you go to the residential treatment center that specializes in eating disorders. Well, that's good. So now if you're the professional, you've gone to the eating disorders conference, you've read the literature, you're competent to treat eating disorders, but you know nothing about PTSD, because that's a completely separate category. So now you got to read the PTSD literature. Okay, phew. Oh, wait a minute. Here's somebody with borderline personality disorder. Now I got to read the whole borderline literature, go to the borderline conferences. So it's all divided up in these separate categories as if there's really, really distinct treatments for all these different problems. But actually, in fact, in reality, there isn't. So if you are an inpatient in an inpatient mental hospital facility, you're going to have some kind of DSM diagnoses. But what meds are you going to be on? Doesn't matter what your diagnoses are. If you're an inpatient, you're likely to be on a mood stabilizer, an SSRI, probably one of the newer antipsychotics, maybe a benzodiazepine. So most people who are inpatients are on the sort of varying combinations of these 3 or 4 basic types of drugs, no matter what their diagnoses are. And there's studies showing things like in the late 90s, they did a survey of all the people in the state mental health system getting treated for schizophrenia, and half of them were on mood stabilizers, which supposedly are for bipolar disorder. And then you go to a whole bunch of people with bipolar disorder, a lot of them are on antipsychotic medications that are supposedly for psychosis. So people are on all these combinations of different meds and combinations of diagnoses, and it's kind of like a hodgepodge mess. It's not nice, clean categories where antidepressants for depression, Mood stabilizers are for bipolar, antipsychotics are for psychosis. In fact, 80% of pediatric prescriptions for Seroquel, which is an antipsychotic, are for kids who have no psychotic diagnosis at all. So it's not like we've got these clean disease categories and we've got very specific treatments that are only for that disease category. And then we've got this other disease category with a completely separate, distinct set of treatments, even in the medication area. And in the psychotherapy area, it's this kind of many tools in the toolbox, technically eclectic, flexible kind of way of operating, most therapists most of the time. So therefore, the treatment for the eating disorder, in my approach, is not totally distinct and separate from the treatment for self-mutilation or alcohol or addiction to the locus control shift, because it's all problems not the problem, what's the context, what's the function, what do you need to do in order to get to recovery. But so let's go with the eating disorder now. Because about 40% of people coming to our trauma programs have eating disorders, which is mostly kind of mixed, restricting, binging, purging, vomiting, sometimes pretty pure restricting anorexia, sometimes just binging, purging, but most commonly it's kind of a mix of all the above. So what's the purpose if we're doing binging and purging? So a binge, again, can go from you eat one potato chip, that's not a binge. It's got to be some kind of large chunk of stuff. There's not an exact, how many calories it has to be, but really serious binge purge people will eat 3,000 to 5,000 calories in a sitting. So that's a little more than the average snack. Okay, so what's going on immediately before you binge? Well, life is going perfectly. I feel great, my self-esteem is up, and I'm under no stress? Never. So there's always some bad feelings, bad situations, something you don't want to cope with, and then you start the binge. And what happens when you start the binge? It's always the same story. My focus is now on the food. The whole universe is the food, the binge, the food, the binge, the food, the binge, and all that other stuff is kind of halfway or totally out of sight, out of mind. So I don't have to deal with it. So it's an avoidance strategy. And okay, so that's good. So then what happens once the binge is over? Then I feel really good. Until about 4 seconds later when I go, oh my God, I just took on 5,000 calories. Therefore I'm going to gain X number of pounds, and therefore my boyfriend's going to dump me right away. So if it's an adolescent female, so we're learning that adolescent males who are into sports, bodybuilding, all this kind of stuff, often have eating disorders too. They look a little different, but same sort of stuff. So, okay, so I understand why you binge, but what's the big deal about gaining a pound or two? And a total catastrophe, oh my God. So gaining a pound or two in and of itself is not that big a catastrophe, but what's the belief? The belief is everybody's going to notice, and everybody's going to be appalled, and everybody's going to think I'm bloated, fat, and ugly, and my boyfriend's going to dump me. Well, so the odds that the boyfriend's actually going to notice 2 pounds are 0, but might notice 5 or 10 or 15 pounds, and husbands not uncommonly start berating the person and name-calling them and verbally abusing them if they gain 10 or 15. So what's the real underlying problem then? The underlying problem is unless I'm perfectly packaged, perfectly this weight, perfectly this hair, perfectly this everything, and delivering all these perfect services like sex on demand and so on, I have no intrinsic worth or value. So if I don't keep the package totally right, my boyfriend's going to dump me. And package totally right includes 2 pounds overweight. So the real problem is that if I don't get rid of these calories, my boyfriend's going to abandon me, because who would want to be with me anyway? Because I'm just this miserable, pathetic child who caused my parents to abuse and neglect me. So therefore, I got to get rid of the calories. How am I going to get rid of the calories? I could draw a picture. That doesn't work. I got to do something that actually works. What actually works? We got to either throw it up or use X-lax or burn it off by exercise. So you get compulsive exercising. And then that's good. Because you got rid of the calories, you're back to home base, back to square one. Everything is good for a little while until the feelings build up again. So it's the same treadmill of addiction. It's just the behavior of eating disorder instead. And underneath, there's always the locus control shift. And so I commonly say, the people who come to the trauma program, lots and lots and lots and lots of the time, have very low self-esteem. So we should therefore be treating self-esteem, trying to increase self-esteem. But actually, I don't think that the problem is low self-esteem. It's actually high self-hatred, which is the locus control shift, which is understandable, which is normal childhood cognition, etc. So if you've got this level of self-hatred, self-blame, self-punishment, negative self-talk, you're going to feel good about yourself? It's impossible. So rather than trying to somehow, inflate the self-esteem, we want to dismantle and take away the self-hatred. When you dismantle and take away the self-hatred, my kind of philosophy of life is based on doing a pediatric rotation as a medical student and being around kids as well, just in life. But when I did well baby newborn exams, so I'd go in and check their reflexes and listen with a stethoscope and stuff. And here's all these like gorgeous little babies. As long as they're not too hot, too cold, too much of a dirty diaper, too hungry, they're basically all okay. They're in I'm okay, you're okay mode. And they kind of like being touched, and as long as you don't keep them, outside in the Canadian winter while you're examining them. So the default position of the organism is I'm okay, you're okay. I'm good, the world's good. That's where we all start from. So if you just take away all the negativity, all the negative feelings, all the negative beliefs, you just kind of get back to I'm okay, you're okay. So we don't have to build up self-esteem so much. We do a little bit, but that's kind of my approach. And so then if it's an eating disorder, we're not really working on the eating disorder again. We're working on the locus control shift. The problem is not the problem. And so that's good, but let's see if we can push this idea, this model, to an absurd extreme. So here's the absurd extreme. So there's a 28-year-old woman who comes to the Rape Crisis Center. She didn't have an abusive childhood at all. She's been sexually assaulted, raped last week, and she's having flashbacks and nightmares. And the worker there, the therapist, has read the trauma model therapy book. So the worker says, well, you're really just having flashbacks to solve some other problem. The flashbacks aren't the problem. So that's horrible therapy, right? So this, for the therapist, you got to remember the whole art of therapy. It's all about the timing, how you deliver it, your tone of voice. You can't just beat people up with the problem is not the problem. But nevertheless, just sort of intellectually, how could it possibly be true that having flashbacks and nightmares is not the problem? Well, what problem could possibly be solved by having flashbacks and nightmares? So it doesn't really make any obvious intuitive sense. And it took me a fair number of years to figure it out, that even PTSD can fit the problem is not the problem. Okay, so how or why? So back in the 90s, I was working with a really severe, complicated childhood trauma, severe, complicated symptoms diagnoses person. And I noticed that she was holding on to her symptoms really tight. So I tried this approach, I tried that approach, this strategy, that strategy. Nothing was going anywhere. And so then I said to myself and then said to her, you seem to be holding on to your symptoms awful hard. Why don't you let go? Which I thought was a sensible question to ask. Why don't you let go? because she was clearly not just kind of passively stuck in the symptoms, she was actively holding on to them. So I asked her the question, so she was very helpful. She explained it to me. Oh yeah, you want me to let go? That's what my perpetrators have been telling me my whole life. Let go. And what does the perpetrator mean by let go? The perpetrator means, don't talk about it, don't bother us with us, pretend it was no big deal, and get on with life. So let go actually means invalidate yourself, deny how serious it was, deny the impact, and don't cause any trouble for us. So if you were to let go, you'd be totally betraying and invalidating yourself and just acting like the perpetrators. So you're not going to, therefore you're not going to let go of the symptoms. So this is what she explained to me. So I said, well, thanks for explaining that. That totally makes sense. But maybe there's another option. Maybe instead of walking around carrying all this burden of symptoms, maybe the coolest thing would not to be living under the shadow of the perpetrator, not to have your feelings, your thoughts about yourself, your beliefs about yourself, what you do, what you don't do, controlled by what the perpetrator did to you a long time ago. Maybe stepping out of the shadow of the perpetrator and not having symptoms anymore, that could be a cool option. That doesn't mean denial, invalidation. That's a different meaning of letting go. What do you think of that? And she goes, I never looked at it that way. I never thought of that. So now letting go of the symptoms becomes a project that you might want to invest in instead of a project that you're going to say no to absolutely forever. So this is the kind of reframing, cognitive aspect of it. So therefore, I realized that the symptoms can be a memorial to the trauma. And I remember the first time I went to the Vietnam Memorial in Washington. That's a very moving place. And the Oklahoma City Memorial for the Oklahoma City bombing, also a very moving place. You go there, Oklahoma City. It wasn't very crowded. It's not that big. It's very beautifully sculpted, sort of Zen, minimalist architecture situation. And there's a little pool there. And then on the slope, there's a metal chair, one for each person who died in the Oklahoma City bombing. So you're walking around, so that's kind of impressive so there's adult-sized chairs, and then you notice, wait a minute, that's a little small chair. And then you realize kids died there. So it's very moving and overwhelming. And that's the memorial to the trauma. So why do we have a memorial to the trauma? To recognize it, to say that it happened, to say that it was important, to remember, to not forget, and to tell the story around the campfire of the trauma, which people have been doing for 100,000 or 500,000 years, telling the story of the trauma to an empathic listener, validating it, going over it, putting it in a context, remembering it. So there's a human need for a memorial to the trauma. So that's the memorial for the Oklahoma City bombing. There's a memorial now for 9/11. Where's the memorial for childhood sexual abuse? There isn't one. There's no place you can go that's a physical statement. Childhood sexual abuse is happening all over the place. It's big, it's important. We need to recognize it. We need to validate it. In fact, so when I was in my residency training from 81 to 85, the Comprehensive Textbook of Psychiatry 1980 edition was the Bible of Psychiatry, which had 3,000 something pages in it, which I still have in my bookshelf, 3 volumes. It's gone through subsequent editions since. So there's like 3,500 pages, 2 columns per page, everything you need to know in psychiatry. Way at the back. So there's the important stuff. And then way at the back, there's a section called Topics of Special Interest, which is sort of irrelevant stuff like strange syndromes that only happen in Borneo. And one of those chapters, very short, was called Incest. So that's a topic of special interest. It's not really relevant to general psychiatry. In that short chapter, there's one paragraph talking about how common incest is, with a reference to a 1955 study saying that it's 1 family out of 1 million in the United States. It's actually more than 1 out of 100. So this is the level of institutional denial in official academic psychiatry in 1980, which has shifted a little since. So now you can't stand up at American Psychiatric Association and say, incest occurs in 1 family in 1 million in the United States. Everybody just look at you like you're completely out to lunch. You could do that 35 years ago, get a round of applause, and you could say at some seminar or workshop, well, I've encountered some adult females who believe that they were sexually abused by their fathers, but it's clearly an edible complex fantasy, it's a false memory. And everybody go, yeah, good. We know this, because incest actually is so incredibly rare. This was what the boys said not that long ago. So there was, not only was there no memorial to the trauma, there was active institutionalized denial that it ever took place. And what's happened since then in the field of psychiatry is we shifted from it doesn't happen at all, it's all false memories if anybody ever mentions it, to, well, yeah, we always knew it was more common, but it's such a fuzzy area, we don't have good data, to, okay, so we got overwhelming numerous studies showing that it's very common, but it's not really relevant to what we do here. And if you need to deal with it, that's in your outpatient therapy or somewhere. So if you come into an inpatient setting or residential treatment setting, in most of the mental health system, you just will not talk about your childhood trauma. It's just not what we deal with here. It's not relevant. It did happen, possibly some false memories in there. It did happen, but it's really not relevant to your diagnoses and what we do here treatment-wise. That's really how the system operates today. So that's no wonder that people hold on to the symptoms as a memorial to the trauma then. What would be another reason to have symptoms of PTSD, such as flashbacks and nightmares? What possible problem could be solved by having a flashback? It's not obvious. Like, you get drunk so you don't have to feel the feelings. That's kind of obvious and easy. So this I understood by reading a book. So most, like 95 or more % of what I write in books, what I understand, how I do treatment, where did I learn that? I learned that by going, okay, explain to me why you do that. And the person who explained to me, now I'm the expert who explains it in the book, literally. So how do I know why people cut? By asking people why they cut. So this is in one exception where I actually learned something from another psychiatrist named Lenore Terr, who's a child psychiatrist in the Bay Area, who wrote a book called Too Scared to Cry, which is based on the Chowchilla bus kidnapping in Central California in the 70s. So these kids hop on the school bus, it's a normal day. 2 guys commandeer the bus at gunpoint. They force the driver to drive to a gravel quarry, and they bury the driver and all the kids under many feet of gravel. And tell them, if you dig your way out, we'll be here and we'll kill you. And they have guns. So they're down there like something like 13 hours or something. Imagine all these kids in a school bus in the dark, buried, no toilet. Whee. They dig out. The guys are gone. Everybody's okay. And the guys are later captured, imprisoned. So she follows these kids up for 5+ years going forward in time, who are all these little magical child thinkers. And what does she hear from a little girl, little boy? You know Dr. Terr? I should have known. Every day, the whole year, Mary sat in exactly the same seat on the same side of the bus. That day, she was on the other side of the bus. I should have known something was wrong. I shouldn't have got on the bus. Next kid, her story is, or his story, you know Dr. Terr? Every day the newspaper boy put the newspaper over here. That day it was over there. I should have known something was wrong. I shouldn't have gone on the bus. So where the newspaper is has zero utility for predicting that you're going to get kidnapped, clearly. So these are, she calls them omens. These are the magical thinking predictors of the future trauma. If only I had seen this, if I only had seen that, then I would have known, then I would have taken evasive action, and then the trauma would not have happened. Problem being, none of these omens have any real predictive value. So right away, we're in locus control shift. It's my fault, I messed up, I wasn't paying attention. If I had been, then I would have known, then I would have done something. So it's my own stupid fault. Okay, so that's automatically locus control shift. And it has this illusion of power, control, and mastery. Because I really had the power, I really had the mastery, I coulda, I just messed up. So in post-traumatic, I'm going to write a paper, hopefully before Christmas, called Pre-Traumatic Stress Disorder. Because post-traumatic stress disorder, which is PTSD, sort of little joke in the paper is going to be, we should rename PTSD PTSD, because PTSD is a better name for PTSD than PTSD. So it's always fun to play mind games. So meaning that instead of calling it post-traumatic stress disorder, we should call it pre-traumatic stress disorder. Because we think that post-traumatic stress disorder is all about the past. What happened in the past is now bothering you in the present. But really, I think post-traumatic stress disorder is at least half, if not more so, a disorder of the future. Really what you're doing is trying to control the future. By doing what? By figuring out the omens you missed last time. How are you going to figure out the omens you missed last time so that you can look for them in the future, and you messed up that time, but you're not going to mess up again in the future? In order to know what omens you missed, you got to review the tape. You got what happened, okay, this, and then, oh, I missed this, I missed that, okay, and then it happened. Reviewing the tape equals having a flashback. So having a flashback isn't just a meaningless, brain on the fritz loop. It's actually a survival strategy to figure out what you missed last time so you can take evasive action in the future. Problem being, there's no objective value in the omen. It's all magical child thinking, no matter what the driver's license says. So therefore, flashbacks are the solution to the problem. The actual problem is it was completely unpredictable, unforeseeable, unpreventable. You couldn't escape it. And you actually were powerless, helpless, and trapped. How would you like to feel those feelings? Nobody wants to feel those feelings. So you shift the locus of control automatically, especially when you're a kid, but since we're all just kids in larger bodies, that magical child thinking doesn't go away. It's still in your brain operating. So therefore, flashbacks have a strategy, have a purpose, make sense, they're oriented to survival. So therefore, the problem is not the problem, even applies to the flashbacks. Even of the person who comes into the rape crisis center who was sexually assaulted a week ago. But you don't just go, hey, shape up. I mean, you have to figure out how to finesse your way in as a therapist. So that's the flashbacks part of it. Okay, so let's imagine that we've got our list of omens now. We've had enough flashbacks, we're good. Well, I don't know, might have missed one or two. Better go back and replay the tape a couple more times. Okay, now I'm fairly confident I got my list of omens. Whew, now I can relax and take it easy. Your omens do you absolutely no good unless you're scanning, hyper-aroused, looking for danger, easily startled. Because then you're going to miss it in the future, just like you did in the past when you were all slack and not paying attention before. So staying hyper-aroused is not so much about being stuck in the past, it's really an eye on the future. But the problem is, you can keep track of where the newspaper is for as long as you want. It's never going to actually predict and help you avoid trauma in the future. So it's all magical child thinking, it's all locus control shift. It's the problem is not the problem. And it's totally understandable that somebody would want to have the illusion of power, control, and mastery. Because who wants to feel powerless, overwhelmed, and trapped?
So is part of moving through that with the example that you
So talk a little louder.
So as part of moving through that with the example that you're using right now, accepting the powerlessness of the situation?
Yes, accepting the powerlessness of the situation and of life. So it doesn't mean we're like totally powerless, right? So, I mean, we're not powerless against the wind because we're inside a building, right? But if a tornado comes by, we're going to be fairly powerless. So, I mean, it's not that we're totally powerless and helpless all the time in life, but there is just a certain core powerlessness and helplessness. And when you were little, that was gigantic and overwhelming. And you've got all these unresolved feelings from childhood that are coming up, and you're operating as if the present is the same as the past, which is the whole definition of PTSD. Why did that combat vet have a flashback and get totally lost in a picture of Vietnam? Not because the news helicopter was objectively that much of a threat. Clearly it was a trigger. So PTSD is always overreacting to the present. And so I explain this all the time. The problem with PTSD, or any apparent overreaction, is that in the present, it can be out of context. It's too much for the situation. But it's not an overreaction to the reality of the past. It's just that the reaction to the reality of the past is getting triggered in the present. That's what happens with mammals. You threaten them with this threat, and they become a little hypersensitive to that threat in the future. I've just been reading a really interesting piece of writing that I'm actually going to do a summary paper of my own on, about fight, flight, sympathetic equals fight, parasympathetic equals flight, freeze. It's actually more complicated than that, but that's a simple diagram. And this guy's writing about Pavlov and his dogs. And so it all starts with observations of Pavlov, and then it comes up to current researchers. And so a lot of animal experiments are actually systematic child abuse on lab animals. And you wouldn't be able to do it to human beings, but we do it to animals. And so there can be dogs or cats or whatever, but it's a bunch of dogs, say, and you have them in their living quarters, and then the handler comes and gets them and brings them to the lab for the experiment. And they do experiments like putting them in cages where they go over to either drink water or eat some food, and then they go back to this part of the cage where it's a little more comfy bedding and stuff, and then they go back and whoop, they get shocked the next time they go back. So they start like shocking them, and then they'll shock them when they go for food, and then next time they won't shock them when they go for food. And then they'll learn that they're safe if they don't go for food, and then they start shocking them when they're not going for food. And so you have this crazy conditioning trials that you can't escape, you can't figure it out, you can't fix it, you're getting shocked. And so it turns out that whatever type of dog it is, there's a certain percentage of the dogs, which this guy thinks for humans is kind of 10%-ish, who are very fight response, sympathetic overdrive, just by nature. So what they find is that there's some dogs, when they go through all these conditioning trials, they get in fight mode. So when the handler comes to get them, they're like aggressive, they're biting, they're trying to fight. And you take them to the lab and they're just like totally attacking. And they go back and they don't settle down very quickly. Then there's another group who are also about 10% of human beings apparently, who are more parasympathetic dominant. And what they do, if they're dogs and cats in the experiments, is they start becoming helpless, frozen, powerless. When the handler comes to get them, they sometimes urinate or defecate on themselves. They hide in the corner. They start drooling excessively. And when you take them back, they get stuck in that mode. They don't just settle down. But the majority of the animals, who are sort of mixed sympathetic, parasympathetic, just genetically, they're all happy and frolicking around when they're in their quarters. You take them to the experiment, they're obviously unhappy, they don't like it, but they go back and then they kind of shake it off and are relatively unaffected. So, and then this model goes into okay, this has got something to do with the mental health field. So if you're just sort of genetically more sympathetic dominant and you get a bunch of trauma, you're more likely to get stuck in fight mode. Or you might be in fight, flight, or freeze mode. So this is actually a way of starting to, and it's all researchable and there's a lot of details to it, but you can get triggered into either fight mode or get triggered into flight mode or freeze mode, depending on kind of which way you lean genetically. And then we've got culture. So how are guys programmed culturally? They're programmed more to go into fight mode. Women are programmed more to go into freeze or flight mode. So there's all these factors kind of interacting, but it's not just that your brain's on the fritz for no reason. The problem is not the problem. Just say no to drugs can even apply to the symptoms of post-traumatic stress disorder. So I've done, so we're going to wrap up in about 5 minutes here. So I've done, written a paper and done a bunch of groups with guys who are sometimes Vietnam, but mostly Iraq, Afghanistan vets. And the title of the paper is Suicide, Self-Blame and Suicidal Ideation in Combat Veterans. And it's basically a locus control shift analysis of guys who, I don't work with them unless, first of all, they were in the military. So they have to be in the military. Then they also have to be deployed. And they have to be deployed to a forward combat role. And then they have to develop PTSD. And on top of that, they have to be suicidal. Otherwise, they don't get into the program and I'm not talking to them. So of all the guys in the world, it's the most traumatized, most PTSD, most depressed, most suicidal group, from whom I think I can learn everything about everything. And so the very common story is, there's variations of all kinds, but a very common story is we're in Iraq, there's a group, we're on patrol, and we get stuck in this firefight. There's bullets zinging all over the place. And I tell my buddy to switch positions with me because I want to get a better look at something or other. 30 seconds later, the sniper's bullet comes and kills my buddy. And it's not exaggerating. I'm literally a murderer. I don't deserve to live, so hence they're suicidal, because I caused the death of my buddy. If I hadn't switched positions, I would have died, which is what I deserve because I'm such a horrible person, and my buddy would have survived. And I've also worked with people where it's exactly the opposite scenario. They didn't switch positions, and the bullet hit the buddy, so they should have switched positions, they should have known, and then, so here's me, the civilian, Canadian by birth, now dual citizen, so never been in the military, never been in combat, and I'm going to tell these guys what's going on? So that sounds a little presumptuous. But the whole reason I have some sort of therapeutic leverage is I'm outside, it didn't happen to me, I can use my adult mind, and they're stuck in magical child thinking. They're stuck in locus control shift. It's magical thinking. And so I'll actually just walk through it in some detail. Okay, well, hold on. So you got hit by a sniper, right? And there's 14 guys in your group. So why didn't anybody take out the sniper beforehand? Well, because bullets all over the place, and so you couldn't actually see the sniper. Is it fair to say that snipers, let's just talk about American snipers, they're pretty well trained? They're pretty good at hiding in a sniper's nest there that could be 200 or 300 or 400 yards away. So these guys are very skilled, very trained, and they're hard to see. And the reason we have snipers is because they have a lot of kills added up. Right. Okay, so if snipers were totally incompetent and everybody saw them in advance and took them out, there'd be no point in having them. So the reason that you didn't see the sniper is the high skill level of the sniper, how far away he was, how well hidden he was, and the firefight that was going on. So maybe what we should do is court-martial all the other guys in your group for failing to take out the sniper. No, 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 no. So there's always a double standard. They're not to blame. I'm not angry at them, I'm only angry at myself because I had the power to know exactly what trajectory that bullet was coming on, at which moment in time, and therefore I shoulda, coulda. This is exactly like the rape victim. It's all the same sort of thing. The problem is not that it was your fault. The problem is that you were powerless and helpless and couldn't fix it and couldn't escape it, which feels horrible. But the burden of self-blame you're carrying in order to avoid those feelings, you sure that's worth it? You sure that's the way you want to carry on? And they'll actually start, it's also obvious in a way, but it's not obvious when you're in it. It's always obvious that you should stop drinking. Oh, you know, that sexual acting out's not really working for you. Not so obvious though when you're in it, which is why it's good to have some help from the outside. And then I'll commonly then do one or several different strategies. I may talk about the buddy who died. And so I may ask the person, do you believe in life after death? What's your religious viewpoint? And they may or may not. But I'll say, okay, well, just let's go with, if your buddy was sitting in heaven watching, and he's listening to this whole conversation, what do you think he would be saying to you? He's saying like, get over it already, get on with life. It's because the buddy may be kind of, you know, giving him a little tough love there. Do you think the buddy's saying, well, gee, I didn't get to come back and live a life. I never got to be married. I didn't get to walk my daughter down the aisle at the wedding. I never got to play with my grandkids. And I sure hope you don't either. Or do you think he's saying, at least one of us got to come back. One of us should have a life. So maybe you should treat yourself the way your buddy is looking at you. So I'm getting them to look at themselves through the eyes of the buddy. Just like the woman who self-mutilates, I'm trying to get her to look at herself through the eyes of her daughter, who loves her unconditionally, or sort of do a quick body transplant, put herself in her daughter's body. What would be your attitude towards you if you were inside your daughter's body with the same attitude you actually have towards your daughter? So I'm always trying to change the viewpoint to get outside of the negative thinking. And I mean, you can see serious big shifts in how somebody feels, what their level of suicidal intent is, what their commitment to recovery is in a single cognitive therapy session. And then I go to the team meeting and I say, oh, I worked with so-and-so on this, and they went from here to there, and I explained to them that locus control shift is not their fault, and the staff goes, geez, how come when you say it, it sinks in? We already said that 20 times. You know, well, that's why it's fun to be Dr. Ross. So none of these things are just say it once, okay, we're good to go. It's rework it, practice it, rework it, practice it, sinks in some more, then you kind of forget it, then you slide back, and then you recommit. That's the path of recovery.